Well enough? So what I do overlaps a little bit with what Dr. Kozlik did, and I was listening to him talk, and I'm listening to him try to explain what an alien limb looked like. And I hope you don't mind, we're going to have just a little bit of overflow, but I actually had a videotape in my computer that shows this. And so the fellow on the corner there, let me just go back, is modeling things to do. And this fellow, his left hand is affected, like Dr. Kozlik said, is trying to do them with his left hand. And you can see the asymmetry, the apraxia. Right hand is fine. Every now and then he brings up his right hand to try to help his left hand. So he's trying to do this. And this is just an example of what Dr. Kozlik was talking about. You can see. But now I'm not going to talk about CBD. I'm going to talk about disorders which are degenerative disorders, which are sometimes confused with FTD, at least initially, that are in the spectrum of Parkinson's disease and Parkinsonian disorders. So it's going to be Parkinson's disease and dementia with Lewy bodies. And as you'll see, these are really very similar conditions which are on a spectrum and can merge into each other. And it really depends on whether the motor symptoms of Parkinson's disease are predominant or whether the cognitive features of dementia with Lewy bodies is predominant. So I thought I'd start with an illustrative case. This is actually, you're going to see there's a videotape that goes along with this. This is based on a woman, which would be, actually, this is actually not a real person, but it's sort of a composite of people that I see frequently in my office. Well, that's good. I'll get rid of this. There, all right, great. So this is a composite of a type of patient that I would see in my office, and it gives you an idea of the kind of combination of motor symptoms and cognitive features that are very typical in people with Parkinson's disease with cognitive problems or dementia with Lewy bodies. So this would be an older woman, 73 years old, 4-year history of simultaneous onset of motor and cognitive problems. Not necessarily predominantly memory problems, probably a lot of trouble with concentration and staying awake, probably. These are very disabling. In addition to the memory problems, she has motor problems and falls frequently. She's asleep a lot during the day, and at night she has these visual hallucinations. I think the visual hallucinations are really a hallmark, as you'll see, of PDD and DLB. Now, PDD stands for Parkinson's disease with dementia, and DLB stands for dementia with Lewy bodies. Since you see the loss of facial expression, stooped posture, these are all the classic motor features of Parkinson's disease. This is just a chance to get you oriented to this. So in terms of where we're going to go for the rest of the talk, there's, I guess, 3 main objectives. One is to talk a little bit about what I mean by PD, DLB, PDD, and hopefully you get enough of that. Review some of the key diagnostic features, including some new diagnostic tests, really imaging tests mostly, that are becoming available to help diagnose these conditions and also, to a certain extent, differentiate them from other dementing disorders. And finally, I'm going to talk a little bit about treatment. And I guess unlike CBD, for example, which Dr. Kozlik just talked about, there are some treatments for some of the features of Parkinson's disease with dementia and also for dementia with Lewy bodies, but clearly we need better treatments. So in terms of terminology, we talked about PD, which is Parkinson's disease. This is really a pure motor syndrome, at least clinically, with rigidity, bradykinesia, and tremor. And it looks really quite a lot like the woman I just showed you on the video. Dementia with Lewy bodies is a term that's used to describe people that have these motor features but also have cognitive problems. And the cognitive problems come on at the same time or even sometimes precede the motor features. And then Parkinson's disease with dementia is really the same basic combination, but the order is different. So people get the motor features first, and then after about a year, and this is really an arbitrary distinction, then they develop cognitive symptoms. And then you'll see that Alzheimer's disease and FTD and other dementias can be distinguished fairly well from PD and PDD in a lot of cases based on a combination of clinical features. So in terms of what is the cognitive picture that you see with PDD or DLB, it's really a little bit of the same frontal picture that you all probably are used to in terms of difficulty with planning and organization and apathy. There's also, the other thing that's really important is that in addition to the purely cognitive features, get this to work. There we go, good. These affective features, depression and apathy, are very common. There's really a continuum of dysfunction. In other words, people go from having very mild symptoms, especially in Parkinson's disease, where people who really feel that they're clinically normal can actually have mild problems. And I think this is actually a thing I'm going to return to at the very end, that Parkinson's disease oftentimes actually progresses to develop dementia just the same way that people with this condition called mild cognitive impairment, which is sort of mild symptoms of memory problems, can often progress to Alzheimer's disease. And this is both a problem because people are high risk, much higher than they'd like to be, but I think also an opportunity because it helps us identify a group of people who are at high risk and potentially who could be treated with a preventive agent if such a thing was available, which would ultimately prevent or delay these really devastating combination of motor and cognitive features. So the core clinical features of PDD and DLB are Parkinsonism, visual hallucinations, and these what they call cognitive fluctuations. And I'm going to take a minute and talk about each of these three things separately. But these are, I think, when you think about what are the core features that really make DLB and PDD different from other dementing illnesses, these are the ones that I think of in my office. So Parkinsonism, we always talk about the cardinal features that James Parkinson described in 1817 as being tremor, rigidity, and bradykinesia, or slow movement. And so this is really the core features of Parkinson's disease. But in addition, they have these other features which are really, I think really almost universal: mass face, balance problems, especially in more advanced cases, soft voice, and small handwriting. So these are this is Parkinson's. These are the motor features that we see. Visual hallucinations. So I think we treat these visual hallucinations in the office with some of the same medications used to treat schizophrenics or people with severe mental illnesses, but they're really quite different. And usually they're formed visual images, and sound is really rare. And this is a major distinction between the kinds of hallucinations that people with psychiatric disorders have, which are usually auditory or voices. So I think that maybe we call them hallucinations, and that's a correct term, but I really think they're qualitatively different than the kinds of problems that people with psychiatric disorders have. They're generally non-threatening. People see small animals in the room, small children. They'll see their relatives sometimes. Sometimes they can be threatening. They'll see like the police in the backyard, but mostly it's small and non-threatening things. And although as a clinician, when I talk to people in the office, I say, "Are you having visual hallucinations?" And I always feel like I'm asking them a sort of a disturbing question. And sometimes people look at me sort of, curiously and said, "How could you ask me that kind of thing?" But a lot of times people will say, "Yes, I see them, and I see children, I see animals," and they're surprisingly not bothered by it, even though it seems like such a strange thing. So they really are very non-threatening. And most of the time, people will have insight that they see this, "Oh, I'm seeing the children again. I know they're not real." And I look over there, I look a little harder, and then they disappear. And that's sort of the typical way people describe it. Sometimes, though, people will look over, and they really don't disappear, and they will try to talk to the images and so forth. And so sometimes the insight is retained that these hallucinations are actually, products of the mind. And sometimes the insight that they're not real is not retained. And obviously, when people can't tell they're real, they become more of a problem. And then fluctuations are the last thing. And when I first started seeing patients with PD and PDD, I really had a hard time understanding how people with a chronic progressive condition where the brain is really the same from day to day, over short periods of time at least, could have good days and bad days, which could be so dramatic, where some people would be fine and really function normally and go visit their relatives, and the next day they would just not know anybody, be asleep the whole day. But it's really, it's very true that these patients have these vast, really major fluctuations between good days and bad days, and it's really common. And I generally tell my patients who have this to take advantage of the good days and write off the bad days as much as possible. I think that this staring into space for long periods of time, really being hard to, even though they appear to be awake, some people get tested for seizures. I did a little of this when I first started. I've pretty much stopped doing it because they're never seizures. They're just brief periods of sort of being almost asleep but with your eyes open. And the thinking, the cognitive function can also fluctuate as well as the level of awareness. So it can be really dramatic fluctuations both in the ability to stay awake, and the ability to think and remember that can occur during the period of the day, over short periods of time, or over whole days. So those are the three main features I think of: the fluctuations, the visual hallucinations, and the Parkinsonism. It's really sort of setting PDD, DLB apart from other dementing disorders. And I'll show you a little bit more about the cognitive profile in a minute. So one question that comes up is, are PDD, Parkinson's disease with dementia, and DLB different, or are they the same? And I think there's probably a growing consensus that they have a lot in common. They're probably more the same than they are different. And the real difference is not so much in terms of the features, but what comes first, what part of the brain is affected first. Because once everything is manifest, the cognitive and the motor features, they really can't tell the patients apart. And pathologically, and when patients come to autopsy and you look at them under the microscope, you also can't tell them apart. This is a relatively, I think, fairly extreme statement that was, but nonetheless, published in the medical literature quite recently, saying there's essentially no clinical difference between PDD and DLB. I think most people would say there's no pathological difference, but I think that in terms of clinical difference, there's still controversy about whether this presentation of the order of symptoms, whether the motor symptoms coming first, followed by the cognitive features, or the cognitive features coming either before or simultaneously with the motor features, actually represents a difference in terms of clinical management and prognosis. So switching gears a little bit to talk about how is PD and PDD different from Alzheimer's disease, I think you do see clear differences between Parkinson's disease and Alzheimer's disease, or FTD, or other sorts of dementing illnesses. And I think I just tried to summarize it a little bit here. So for PD and PDD, you really see the so-called subcortical picture, which is executive problems, retrieval memory, but not free recall, but really importantly, attention. This means both being able to concentrate and also being able to stay awake, and this sort of apathy and depression component here. With the other ones you see for behavioral problems in FTD, more language problems probably in FTD, and also in Alzheimer's disease, and more memory and coding problems that you see in Alzheimer's disease. So I think the take home here is that in addition to having these non-cognitive features in terms of hallucinations, the fluctuations, and the Parkinsonism being distinguishing features, there's also a distinct cognitive profile. Clearly there's overlap. I shouldn't say that there's not, and I think Dr. Kozlo alluded to that a little bit a minute ago. There's clearly overlap between all these syndromes, but in the classic presentation you do see these differences. And actually, in terms of telling them apart, the visual hallucinations is really good. The extrapyramidal features is very good here. The cognitive deficits, I think, in terms of this is visual spatial and this is a pentagon drawing, are not as good. I think so that what I'm trying to show here is that there's clearly overlap in the cognitive features, especially in terms of visual hallucinations. You can really see that that's a distinguishing feature. If you see visual hallucinations, it's probably a Lewy body disorder and probably not one of the other dementing illnesses. Also, I want to emphasize here these depression, cognitive fluctuations, falls, visual hallucinations, Parkinsonism. So these are all the really distinctive features of PDD, DLB that distinguish them here from Alzheimer's disease. But the same could really, that's just this study, but the same could be said for...
Could you explain Lewy bodies?
Yeah, I'm going to get to that in a minute. So the question was, could you explain Lewy bodies? And the next section of the talk is on pathology, and you'll see plenty of Lewy bodies. I'll show you in a minute. We'll go back to that. So just to summarize this part about what's different about PDD and DLB from other disorders. So they're really very similar to each other, and the main distinction is probably the order of development of the symptoms. Affective symptoms, visual hallucinations, fluctuations are the hallmarks of the neuropsychological feature and really distinguish PDD from Alzheimer's disease, FTD, and other dementias. So those are the key take-home points from that section. So here we go, some Lewy bodies. I'm going to go back. So this is a Lewy body. We'll go this way. So here. So the problem with Parkinson's disease is really predominantly, at least in the early phases, loss of neurotransmitters, principally dopamine, but also other important neurotransmitters that affect cognition, like acetylcholine. And this is a normal brain here. This is where the dopamine is made, these black areas. And here is a patient with Parkinson's disease. You can see those black neurons that make dopamine are really lost. And This is showing these pigmented neurons close up, and this is showing them in Parkinson's disease again, missing. And this is a Lewy body. So Dr. Lewy is actually a Philadelphian. He was a refugee from Nazi Germany and came to work at Graduate Hospital, which just became part of the Penn system. And he's the first person to describe under the microscope these cytoplasmic inclusions, and they're round. And they really are the hallmark pathologically of the neurodegenerative process in Parkinson's disease, dementia with Lewy bodies, and PDD. And they start out predominantly in the brainstem and midbrain, and then they migrate up to the cortex, the thinking part of the brain, and that's when you begin to see more of the cognitive features of Parkinson's disease and PDD and DLB. And this just sort of shows how this happens. These are probably we see no symptoms here, or maybe very mild symptoms. Here, the pathology starts to migrate up from the brainstem. This is this gray matter, the squash of your brain where you do your thinking. This is the part down here that controls movement. And you can see as Parkinson's progresses, in that classic PDD way, you see more problems with cortical involvement, more thinking problems. In DLB, you just turn this around, and you'd start here, and you'd have the cognitive problems and the motor problems coming on more or less at the same time. So let me show you some interesting imaging. You can actually image a few things. These are some biomarkers you can use. So this is normal, and this is advanced PD. This is early PD. And what you can see here is this is the dopamine signal in the brain. Early PD is a little bit lost. Advanced PD is a little bit lost. These are two different scanning techniques. They show more or less the same thing. These are scans, especially this so-called DAT-SPECT, which is probably going to be available in the United States to use as a diagnostic in the next 3 to 5 years, I'd say. There are what they call phase 3, which is the final phase of clinical trials going on now, and it's actually already available in Europe. Oh, shoot. I have a little technology problem here. So this is basically showing the same thing in a patient with dementia with Lewy bodies, and this is the data here. What I want to show you here is here's the DLB patient, and here's the PD patients, and you can see that there's loss in both cases, but here you lose it in the caudate and the putamen about the same amount, which, if I go back here, sorry about this, which basically means this part is the thinking part, and this part is the movement part. And in Parkinson's, this part would be okay, and this part would be really a problem. In a DLB, you see equal amounts of loss, both in the motor part and the thinking part. So you could argue to a certain extent there's a specific signature of DLB that you see on these new scans, which again will be available sometime soon. You can also, you might have seen this already. This is a new kind of scan. This red stuff is amyloid deposition, which is bad. And you can see amyloid deposition in Alzheimer's. You can also see it in DLB. So this is another way. This is also available for research and may be available clinically of some sort relatively soon. This is another way that you can image abnormalities in the brain. You could go get a scan, basically, and see if either you're having memory problems, you confirm that it's due to this, or even these problems actually probably come up before people are aware, they show up on the scans before people are aware of them clinically, and this may be a way to predict dementia in Parkinson's patients. I'll talk about that a little at the end. And then here you can see this is acetylcholine, this is normal, this is PDD. You can see the loss of that particular neurotransmitter again. Another way that you can see, you all see the difference between this and this, the loss of the green? This is another way that you can actually have a scan. This is a real patient. This is done as research now, but it could be done clinically in the future to tell whether people are having memory problems that are due to this specific problem with neurotransmitter loss. So I think about 5 more minutes. So a little bit just to wrap up with treatment. There is treatment for PDD, DLB. We wish it was better, but there's treatment for motor symptoms, behavioral symptoms, and cognitive symptoms. For motor symptoms, there are a lot of drugs to treat Parkinson's disease. You're probably aware of that. But for people with dementia problems, in addition to the motor problems, carbidopa-levodopa is really the only one that you should use. It has the least side effects. All these other ones down here have a strong potential to cause cognitive side effects and really shouldn't be used in patients with PDD or DLB. Are you all adjusting to this PDD, DLB terminology? Especially, you've probably seen people have had these implants for Parkinson's disease. These are really not indicated at all for people with PDD or DLB. They're really only for people that are young and cognitively in very good shape. So In terms of motor treatment, carbidopa-levodopa is really the way to go. Visual hallucinations, there are several atypical neuroleptics, so-called, for treating visual hallucinations. I think the best one is this one called clozapine, but it does require regular blood monitoring because it can cause dropping in the white blood cell count on rare occasions, so it's cumbersome. Quetiapine is another atypical neuroleptic which can be used, doesn't require the blood monitoring, not quite as strong. I think the real take-home here is that typical dopamine blockers like haloperidol or risperidol, which often get used in elderly patients in nursing homes, for example, really make the Parkinson's worse. And people with DLB especially are super sensitive to them and can be frozen like a stone by them. So typical dopamine blockers should not be used. Clozapine is the gold standard, and quetiapine is an alternative for people who don't want to get the blood monitoring. I think the take-home here is that the visual hallucinations are a treatable problem in PDD and DLB. I think that stimulants can be somewhat useful for people who are having this problem with staying awake and fluctuations. Cholinesterase inhibitors like rivastigmine and donazepam are options, but aren't very effective. I think one of the key things here is to avoid harmful sedating medications, and bladder medications are an example of this. Antihistamines are an example. Some anxiety medicines. So people who are really drowsy during the day, I think one of the things you can do in terms of medications is not so much add a helpful medication, but look hard at the list of, sometimes people are on 15 different medications, and you can take away the ones that are a problem rather than starting ones that are meant to be helpful. This is just a quick example of in PDD how people who were treated with rivastigmine were better in one clinical trial, but it's not a panacea. It helps a little bit, worth a try, but clearly not the final answer on treating PDD. Non-medical issues, the combination of motor and cognitive features is highly disabling. It can be very distressing both for the patients and for the spouses and children of patients that have PDD. And it's really hard to overemphasize how having trouble thinking and trouble moving at the same time can be a really, really limiting combination. And unfortunately, as Dr. Kaza was saying earlier, this is a degenerative condition, and these impairments are progressive in spite of therapy. And one thing I always tell my patients and their caregivers is that it's really it's a hard job. I think there's this emotional component. There's a major physical component too, because there's a lot of like lifting and dressing that has to go on. So I think that adequate sharing of the responsibility is really important, and the caregivers need to make time for themselves. It's absolutely crucial that they have time during the week and have the rest of the family pitch in and bring in caregivers, they actually paid caregivers if possible. A lot of people are really resistant to this because they feel like they have a commitment, but I think that it makes people better caregiver in the long run if they can make some time for themselves and they don't burn out. And then educate. I always try to educate people that it's okay to make some time for yourself, and hopefully this message gets through. So I just want to finish up on the future. So I think that what we saw is that PDD and DLB are obviously disabling and harm and to be avoided. That the prevalence of these conditions, I didn't talk about this so much, but over 8 years, if you follow a patient with Parkinson's disease for 8 years, the risk of becoming demented is close to 80% in some studies. So it's actually, this is a pretty common but late problem with Parkinson's disease. We have these imaging techniques which can probably pick up these problems before they become clinically manifest. In other words, we can find physiologic evidence that somebody's at risk before they're aware of it, before they're aware of any problems. So I guess my final point is that maybe what we need to be thinking about with our Parkinson's patients is trying to not just do something about PDD and DLB once they already exist, but doing something to try to prevent it. And I think that prevention is, among these neurodegenerative conditions, the potential to prevent dementia in Parkinson's disease is about as good as any place. And I think this is where the future is, that we're going to hopefully have therapies that will delay the emergence of dementia rather than just try to treat it once it exists. So thank you very much for your time.